Okay, then if you don't mind, we can start.
Okay.
The presentation. Okay. Well, good afternoon, everyone. My name is Antonio Carcas. I'm clinical pharmacologist at La Paz Hospital. And I am also the coordinator of the clinical practice guidelines working group at TransplanTchild. Thanks for attending this webinar about the immunosuppression guideline in development for TransplanTchild. The protocol for the development of this guideline has been published in the British Medical Journal Open. You in the slide you have the DOI, and you can access freely to the protocol. After the literature search and the selection of the articles, we have extracted the data from the different studies, and we are starting to analyze them. So in this webinar, we are reporting, we are give the data, the results of conversion, minimization, and withdrawal in 4 outcomes: acute graft rejection, chronic graft rejection, graft loss, and patient survival. I must say that the results are a little bit disappointing because it is very difficult to join all the results in a unique analysis or meta-analysis, because there are a lot of variability in a lot of factors. The first results I present you is the conversion, is related to the intervention of conversion of the immunosuppression drugs, and the outcome is acute graft rejection at any time. As you can see, we have 14 studies, 5 randomized controlled studies, 4 prospective cohorts, and 5 retrospective cohorts. The problem, well, you can see how on the left of the figure that the numbers of the patients usually quite low, except 2 of them. Also, there are obviously different types of studies, and also the time for evaluation of the outcome, it's also quite different, ranging from 3 months to 60 months. So it's difficult to get a clear idea of the results of this intervention with this data. In addition, there are the interventions are very heterogeneous. Therefore, we have some conversions, or so we can evaluate, or you can see the evaluation of 3 drugs versus 2, or the conversion, for example, from azathioprine to mycophenolate, and so on. So it's quite difficult. That's why we haven't done a formal meta-analysis. We just represent here the results of each study, and you can see in the circles, in the red circles, the results of the randomized controlled trials. As you can see, there is no clear picture of the incidence of acute graft rejection. There is one of the studies that has 200 subjects with that favors conversion, but the other results are not very clear, and so and also the intervention are quite different, and also the follow-up of the time point for evaluation of the intervention. Well, if you want to make some comment in any time, please do it. Just raise your hands or open your microphone and make the question, okay, or the comment you want. The second outcome for conversion will be the chronic graft rejection and at any time. We have the similar picture, but even with more difficult because the confidence intervals are very wide in all the cases. As you can see, the numbers of the trials, the sample size of the trials is very low, and also the same heterogeneity in the trials is found. So here is quite difficult to get any conclusion. In relation with graft loss at any time, we saw the same picture. Unfortunately, we have 14 studies, 3 randomized controlled trials, 3 prospective cohorts, 8 retrospective cohorts. If we see the randomized controlled trials in red here, and the results are only no differences we can find between the both control and experimental intervention. In one case, the results can be estimated because no events have been recorded in the trial. We have also in some prospective and retrospective cohorts benefits in one. This is one study at different with evaluation at different time points, and this is another one changing azathioprine by mycophenolic, and we can see some benefit of the intervention arm, of the experimental arm. In other cases, there are no statistical differences. Also, we can find here a statistical difference, also changing azathioprine by cyclosporine. But globally, it's difficult to get also many conclusions. In relation with patient survival, we find similar results with very wide confidence intervals, some very few randomized clinical trials. In this case, we have 4 randomized clinical trials, 3 prospective cohorts, 8 retrospective cohorts. Also, the numbers in most of the cases is quite low. We have only the case of the study by Kranzberg with 2,200 patients. But despite this, the number of events is so low. This is logical, obviously, that the confidence interval are very wide. In the case of the study for Chavers, we can find a statistical difference at 12 and 60 months after the conversion, and this is the unique, the only trial. In relation with minimization, the data are very scarce. We have only 2 trials evaluating chronic graft rejection at any time at 12 and 60, and as you can see, the events are, the numbers are very low, so no conclusion can be obtained. And in terms of the patient survival, also at any time, also we haven't any event, so also it's not possible to analyze that. And the numbers is obviously very low, the sample size of the study. One of the interventions that we have some better data are steroid withdrawal. You have here in the slide the the outcome of acute graft rejection at any time. But in this case, there are also few randomized clinical trials. We have 4, 2 prospective cohorts, 10 retrospective cohorts, and the results, individual results, are in most of the cases not significant. We have one here by Chakrabarti, but this trial, in fact, is not a comparative trial, but is a conversion, and they split the cohort in those patients that can be withdrawn from the corticoids, steroids, and other arm that is not possible to withdraw the corticoids from them. So this study is not valid, and we need to withdraw this study from this analysis. In this case, we have made an analysis of the events of acute graft rejection at different times. Here we can find some differences in at some time points. For example, at 6 months, although as you can see, the interventions are not the same in all the cases, are similar but not the same. Also, in the case of the acute graft rejection at 12 months, we can find statistical differences. In fact, most of the studies are sampled with very low sample size. The events are also low, and therefore, in most cases, the confidence intervals are very wide, and the global analysis doesn't show any differences, although the confidence interval is, in fact, rather high. In relation with the evaluation at 24 months, we also can find also different strategies, and we can find an almost significant difference favoring the withdrawal. In relation with the chronic graft rejection, after steroid withdrawal, we can find any conclusion. The numbers are very low, and it's not possible to find. It's the same study at different time points, and no differences can be found. In relation with the graft loss, you have here the graphic, the figure on the table of the studies, all the studies we have at any time, as in the preceding cases. We have 16 studies, 3 randomized clinical trials, 3 prospective cohorts, 5 retrospective cohorts. 1 is not classified. We will not be able to classify the type of study. We can find here that there is the same that Chakrabarti that I commented previously. As you can see, also there are, and sometimes that we can estimate the difference between both arms. And in any case, most of the cases, the confidence intervals are very well. There are several studies that evaluate at different times this outcome. So it's difficult also to get a conclusion. This is the analysis with meta-analysis, with joint analysis, statistical analysis at 6 months and at 12 months, and we can find any difference between the different strategies of steroid withdrawal. In relation with, there we have also data for graft loss at 24 months, 36 months, and 60 months. And well, as you can see, it's difficult to obtain a clear picture, although sometimes you can find the benefit of withdrawal, but the type of study are retrospective cohorts, and probably because of the time of the evaluation, it's difficult to know if how is these figures relate to the previous graft loss or graft or problems that the withdrawal could have for the patients. In relation with patient survival, we have 12 studies. Each color, as previously, shows different studies with different time points of evaluation. We have 4 randomized clinical trials, 3 prospective cohorts, and 5 retrospective cohorts. In this case, also because of the low or no existing events in many studies, obviously no estimation can be done. And in any case, the confidence intervals are very wide, so it's very difficult to obtain any conclusion. So, as I said, the conclusions or the results are quite frustrating after reviewing such a high number of publications. And the main conclusion is that the evidence recovered from the literature in children make it difficult to obtain conclusions about most of the interventional outcomes. And the reason for that are already mentioned. First of all, the very scarce number of clinical or randomized clinical trials, many retrospective cohorts. Most of the studies have small sample sizes. It's difficult to join the different intervention and controls in comparison. So we have a high heterogeneity in this aspect. Also, after reading a lot of the papers, we have found that there is no clear and standardized definition of outcomes, and I think that will be something to correct, or maybe we can propose some core outcome sets and with clear definitions, with recommending the follow-up periods, recommending how the outcome should be defined, how should be evaluated, and so on, in order that all the publications, being randomized clinical trials, cohorts, or whatever type of study, use the same definition of outcomes, the same times for follow-up, and the same and as possible as if possible to define the best intervention to check all these aspects. Also, we have a lot of publication with no standardized way of reporting of results. In most of the cases we have seen today, the results are a yes or no outcome, but we have found, for example, in growth or renal function or graft function, different ways to report the results. That obviously that's difficult very much the analysis, the joint analysis of the results of different publications. As we have shown, only corticosteroid withdrawal will allow we will like that allow some quantitative analysis, and the results point to that no increase in risk of acute rejection with corticosteroid withdrawal. We haven't conclusive evidence in the case of chronic rejection. It seems that no increase of risk for graft loss are in the studies, but the confidence intervals of the intervention are very wide. So we will need a more precise estimation of this outcome. And in terms of patient quality survival, this is probably very rational. There are very few studies. The studies are all of quality and with short follow-ups, and so no conclusion can be obtained. Maybe it's not very important because it's clear that it's not very probably that the patient survival is affected. Obviously, we will need to analyze other outcomes associated to corticosteroid withdrawal, as growth or graft function, to be able to clarify better the benefits of steroid withdrawals. So our next step in the development of the guideline will be to make some rounds of consensus panel by organ and trying to evaluate the data I have presented to you and the other outcomes we still haven't analyzed it, in order that these organ panels will evaluate the evidences. If it's possible, the panel members could add any other evidence they are aware of. This would be quite necessary, probably. And also, then the panel will review the evidence and answer if the established questions are suitable. Then about give their opinion about the need to split some strategies, and if the panel have subsidiary questions within the main question that should be addressed. And hopefully we could reach some consensus about these issues. Our first proposal for the partner composition for kidney are those people that you can see in the slide. Those in red are those people that have confirmed their participation, and we have the application forms for the panel, and also the declaration of interest that we have to collect from the members of the panel. We hope that the other members could adhere to the panel as soon as possible. And okay, if you have some question or some comment, I will appreciate them. Maybe my worry is that the evidences are difficult to analyze, and that we should move for a kind of consensus to get some useful recommendation. I don't know what's your views, because I said it's a little bit frustrating and difficult to address this 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 guideline.
Thank you, Antonio. This is Lorenzo. I'm sorry that I don't see any of the panelists now present at today at this presentation. I think
Yeah. We send the invitation to the consortium, to all the net.
Yeah.
But
what I wanted to comment, obviously, the kidney is not my primary field of interest, but as a general comment, I would guess that you will find the same pattern of of different outcomes and results, even for other solid organs and maybe also for the bone marrow, because of several reasons. First of all, the patients are not very many. If you look at the papers, they're very old. And probably they come from the period when there were more enthusiasm with the new drugs. But for a long time, we didn't have new drugs. Actually, the drugs we were using are very old. So it is difficult to produce randomized controlled trials with the same drugs that we've been using for 30 years. And in fact, there are no recent randomized trials. And I think another point is that with the years, we came to the conclusion that transplantation, especially in children, is treatment that should be tailored to the patient, because we have different ages, different indications, which are really important. Because if you have an indication which is an immune-mediated disease, then your immunosuppression usually is not going to be standard immunosuppression. So standardizing might be easier in large populations in adults, but it is difficult to decide to do a randomized trial with two treatments in children when they are so different one from one and the other. So these are just a few comments that I think will apply also to liver, intestine, and other organs.
Yeah, I agree with you. Obviously, it's difficult to do randomized clinical trials or even new intervention cohorts with very old drugs. That is clear. And also, I agree with you the need of tailoring the treatments and to individualize the treatments. And this is difficult to implement within. And this need is difficult to implement within a clinical trial, a randomized clinical trial. That the question is if we are able to learn something on this situation, on the past experience, in the terms of as I said, to try to standardize all the aspects of the intervention of the studies we can do within this within transplantation, in the sense that maybe some new drugs will come, and it should be useful to avoid the problems we had in the past.
Yeah,
it's easy.
Yeah, but I think one point is that that should be raised is that the drug companies didn't have interest to develop new drugs, because for a very long time we didn't have new drugs. So one issue is why the companies are not proposing new drugs. Maybe because they feel that the drugs we use are good enough. Certainly in adults they don't have much problems with immunosuppression. But in children we do, because we have 80 years in front of us. But we don't. So first thing, I think companies are not developing new drugs. For instance, relatively not new, but the latest drugs are the mTOR inhibitors. But these drugs are not registered for all ages, for all pediatric ages. So we cannot even use easily these drugs. And So, yeah. So at the end, I think what you can do is only a consensus conference, a position paper with a consensus and some recommendations based on expert opinions.
Yeah, we have to move. We must move to a consensus that is clear. Probably it was clear before, but well, we try to systematize in some way the review of the literature, but really it's very difficult. That's the truth. Okay. I don't know if there is any other comment or question. No? Well, then, thank you very much for your attendance. Thank you very much, Lorenzo.
Thank you, Antonio. Nice to see you.
And
from distance.
Do you have some free days in the next week or not?
Well, as I told you, I'm in quarantine, so in one sense, I'm very free this week.
I forgot.
I'm supposed to go back to work.
You look very well, so I forgot you were.
Yeah, I'm very well. Yeah. What about you? But there are no holidays to take these days. So where do you go with the lockdown? So anyway, happy Easter holidays for next week.
Okay, thank you. The same to you, and for all. Okay.
Yeah.
Bye.
Goodbye.
Bye.
Thank you, Antonio. Bye.